Dr. Epstein, thank you for being with us today.
It's a pleasure to be here.
Now, you are a clinician at the University of Rochester, a professor, a researcher, but more than anything else, maybe an expert in how physicians communicate. So let me ask you specifically with regards to end-of-life care, what does the research say? How are physicians doing when we have these conversations?
I think that there's a lot of avoidance, but people are really trying their best. I mean, it's kind of these two sides of the coin, that we're all afraid to talk about death. It's scary. It's scary for doctors. It's scary for patients. And it brings up thoughts of our own vulnerability on the one hand. On the other hand, I think most physicians these days recognize that those conversations are really, really important and they need to happen. The dynamic usually is that doctors wait for some clue from the patient to bring up a topic, and patients think that, well, if something is really serious, the doctor will begin talking about these issues. And because of these conflated assumptions, the important conversations just don't happen.
So that brings up this issue of concordance of belief between physicians and patients. And you've been involved with several studies that have tried to measure this. Can you tell us about how different physicians and patients may feel about their prognosis with a given disease?
Well, first of all, prognosis is difficult. I mean, predicting a disease course, even in fairly predictable diseases like stage 4 cancer, still is tricky. There's quite a bit of individual variability. But nonetheless, often we have a ballpark sense of how most people are likely to do. And it's also human nature to want to be optimistic, both for patients as well as for clinicians. But what we see is that even given that tendency for optimism, patients tend to be much, much more optimistic and unrealistically optimistic, even when clinicians claim to have given patients accurate information about their disease. In fact, we see about 20% of patients with stage 4 cancer, for example, saying that there's a 100% chance that they'll be alive in 2 years from now. And of course, no one can say there's a 100% chance of anything. So there's kind of a mismatch. And if you look at clinicians' estimates, they will be often radically discordant from what patients say. They'll usually be quite a bit more realistic. Interestingly, family members of patients are somewhere in the middle. They take a bit of the clinician's perspective and a bit of the patient's perspective.
So physicians are potentially less optimistic. Who is closer to the truth in the end? Have studies looked at the ultimate outcome of patients based on their perceived prognoses?
Yeah, there have been studies that were done a while ago that showed that physicians themselves, at least then, this is in the, I believe, late 90s, early 2000s, that even then physicians tended to be significantly more optimistic than patients' actual disease course. Those studies were done with patients who had days or weeks to live, so very, very short time frame. What we don't know is the accuracy of physicians' estimates when patients have an average of months to live. And we're just currently analyzing the data on that. But just as a sneak preview, I think that physicians are probably pretty accurate. Actually, they may be sometimes a little bit on the pessimistic side, whereas patients are radically inaccurate. They tend to be way on the optimistic side.
I think as a physician then, that was my sense as well, and we go into these conversations sort of knowing that we might be on the more pessimistic side, and that adds to the stress because we're breaking bad news, and often we're telling something to the patient that they don't want to hear. So you deliver this type of news frequently in your clinical practice. You're part of the palliative care group there, among your other roles. What goes on in your mind before you open the door to that room? How do you get yourself prepared for that very difficult conversation?
I think to myself, first of all, I need to have the facts. I really need to, and I also speak to, if it's a patient who's got bad heart failure, I'll speak to their cardiologist. So I really try to prepare myself and have all the facts available so that I really know as much as anyone can know going into the discussion. The second thing is just what I have in the front of my mind is to be compassionate. And compassion is complex because, yes, you want to make patients feel good and feel well. And I think also you kind of want patients to like you, but compassion goes deeper than that. Compassion really means helping people navigate the best way they can the future that we can foresee. And so with that framework in mind, sometimes, it's kind of like giving an injection. It hurts for a moment, but then it prevents something that might be far worse. And so giving bad news always hurts. It always increases anxiety, increases everybody's anxiety. But if in the long run it seems to result in better decisions, in choices that help patients live the way that they want to and concordant with their own values, then you'll say the pain is worth it. But it's still no less painful when you do it.
So I want to touch on hope, because it always sounds great, and it's very tempting when you're having conversations with patients to lock on to that. There's always hope. There's always a chance. Nothing is perfect. Our tests aren't perfect. That seems good, but there are times when a patient is going to make decisions about further treatment or further advanced treatment, potentially based on that hope of a 1% chance of response or even smaller. So at what point is it our responsibility to dial back on hope if we fear that a patient is heading down a path towards a lot of interventions or a lot of treatments that may not be in their best interest?
I think an important question is asking a patient, well, from all you know about the situation you're in, what are you hoping might happen? What do you, let's say things, just using your knowledge, what realistically do you think you're hoping for? When you ask that question, and we've actually studied that, about, I would say, 10 or 15% of patients are hoping for something that's clearly unrealistic, that all their cancer will go away, that their heart failure will somehow improve, that their the liver that they just had transplanted that's being rejected will suddenly restore itself to health. Those kinds of things. I think that another percentage would say, yes, of course I want the cancer to go away, but I know that's not possible. But I really want to be around long enough to go to my son's graduation or some event or something like that. And I think that getting a calibration of where patients are at is the first step. The second is to kind of educate their expectations. So if now it's February and their son is going to graduate in 2 years, I'll say, well, I wish that were the case, but looking at the big picture, it's probably the odds are pretty strongly against that happening. And then giving the person a chance to regroup and to think about, well, what's important in this circumstance. So I think it's not that you're taking away hope or you're giving hope, but I think you're educating people in terms of how to calibrate their expectations.
Now let me flip the situation around a little bit and focus on the physician. These are conversations that are actually very rewarding for physicians. In my personal experience, and certainly with the docs I've spoken to, these are some of the most fulfilling moments we have as physicians. At the same time, they're very draining emotionally. What is your advice to physicians who are going to have a conversation like this, potentially in the hospital with a family, and then have to leave the room and take care of 20 or 30 other patients in the hospital?
Yeah, I think that really calls for a high degree of self-awareness and to understand how those emotional feelings are affecting you in a moment-by-moment basis. And I think that good clinicians develop that and also have a way of setting aside what just happened with the previous patient so you can be present and attentive to the next person that you see, not kind of carrying this baggage with you. I kind of, imagine it's kind of like the left luggage department at a train station. You have this big piece of baggage, you kind of leave it there, it's safe, it's there, you can access it when you need to, but then you don't need to carry it around with you all the time. And some way of mentally refreshing yourself. And I think that, clinicians have a variety of ways of doing that. the emotional impact is huge, but I think it's attenuated by this positive feeling and also gratitude that patients and their families express towards you. So that all of this kind of positive emotion helps attenuate the burden, or what some people call compassion fatigue. At a certain point, it does get to be too much. And then you need to take a break. And what I'll do during the day when I'm on service in palliative care and I have a large service is make sure that I have 5 minutes here or 5 minutes there where I do something that allows me to recharge or at least even be away from the chaos of the clinical setting. So I'll go to my office, or I'll make a phone call, or I'll answer an email, or do something, or just sit quietly, eat lunch without doing something else at the same time. So and for me, just those few moments, those kind of mindful moments during the day, really provide a lot of balance that enables me to keep going. But I do think that there's a threshold, and all of us need to know where that is and to find ways of accommodating.
Well, thank you very much. This is obviously a very difficult topic, and your advice, I can assure you, is much appreciated by the clinicians who have to deal with these types of issues. Dr. Ronald Epstein is from the University of Rochester, and his new book is entitled Attending Medicine, Mindfulness, and Humanity. Dr. Epstein, thanks again.
Thank you.